Good day to everyone. First, I want to thanks Dr. Tariq Khan, who is chairman of WFNS Neurotrauma Committee, and Dr. Corrado, who is the member and coordinator of this ICRAN virtual meeting. My topic of presentation is decompressive craniectomy in traumatic brain injuries. We know that traumatic brain injury is a leading cause of death and disability worldwide, and more than 90% of burden is shared by the low and middle income countries like India. And who is affected? They are youngsters who are the more productive age group, and they are bread and butter of their families. And it caused lot of financial implementation and loss also. An elevated ICP is a primary culprit which contribute mortality in 50% of the TBI, and decompressive cranectomy has become the definite surgical procedure to manage medically intractable pressure due to stroke or traumatic brain injury. If we see the history of DC, the decompression of brain started in ancient Greek, which was propagated by the modern philosopher in medicine, aim targeting to reduce ICP by providing space to expand the brain. And in 1970s, the decompressive nectomy was started, but because of the high mortality, this was not very much popularized. So in 80 to 90, very few number of the cases were done. But again, looking to severity of the burden, the DC was tried with change in the technique. And we found that completely better outcome in the results of decompressive cranectomy. So when routine measures fail to control TBI related brain edema, therapeutic options are very limited. And decompressive cranectomy, when we do, does not reverse the primary injury, but it prevents the secondary damage caused by the persistent or refractory intracranial hypertension. We all know that they are the basic measures we take to treat the intracranial hypertension. So basic measures are sedation, analgesia, patient position, mechanical ventilation, and extended measure like hypermolar therapy, CSF drainage, barbiturate coma, hypothermia, marked hyperventilation, arterial pressure increasing, and finally decompressive connectivity. So these measures require a lot of good instrument and finances, so not available in low and developing countries. So aim of DC is to reduce mortality, long-term favorable outcome, and improve quality of the care. And after the medical management, if the ICP is not decreasing, and by using the brain trauma foundation guideline, then decompressive cranectomy can be planned. So they are the few of our indication where we do the decompressive cranectomy, like clinical status when deteriorating, radiological status, refractory ICH, intracranial hypertension more than 20, unilateral or diffuse brain edema, effacement of cistern, neurological deterioration, or large subdural or intracerebral hematoma. In children, it has been seen by Hejai that in severely damaged children, decompressive cranectomy provide very good recovery, and children suggesting the procedure has advantage over non-surgical treatment. And he followed the patient in for 5 years and found that 65% of the cases there was favorable outcome. The rationale based on the Monroe-Kellin doctrine, where the physical space confining edematous brain tissue after traumatic brain injury will reduce the intracranial pressure. Decompressive cranectomy become definitely surgical procedure to manage where the medical intractable or refractory case of the intracranial hypertension. So this ICP reduction will cause improvement in cerebrovascular compliance, cerebral oxygenation, and cerebral perfusion. Although Hannibal recently told that long-term beneficial effect of BC is still regarded as salvage surgery. Type of decompressive connectomy may be primary when bone flap is removed with the cause of mass lesion, or secondary or protocol driven when there is a generalized edema or unilateral edema, and to overcome this, the bone flap is removed. So, as I told, the technical advancement was better outcome of the patient, like the size of the decompressive connectomy. Like here, it should be 14 centimeter and 3 centimeter from the midline up to the zygomatic arch. As far as the dural closure is concerned, Vera is recently concluded in the study that water-tight dural closure or not done where the watertight closure, there was hardly difference in the CSF leak. In our institute, when patient on the table, we feel that there is a swelling of the brain, patient is unstable, and in number of cases, we never close the dura, and outcome of patient as far as the CSF leak concerned is not much problem, and outcome is better. Decompressive connectomy also has poor prognosis, like advancing age, fatal brain injury with irreversible brainstem signs, herniation with neurological deficit, and there is a evidence of ischemic brain damage, and persistent A wave or B wave is there. So, a number of studies were done. Recently, the DECRA study was conducted where decompressive connectomy definitely lowers the ICP more than barbiturate coma and hypothermia. And this study was having very few number of cases, 155. So, and proved that there was not much difference in the outcome of the decompressive connectomy and standard care treatment. Although there was the mortality in DC was 19%, and in standard care it was 18%. It also shows that the poor outcome in decompressive connectomy was about 70%, and when the standard care was followed, it was a 51%. Then rescue study came, which also shows that 6-month outcome, there was marked reduction in the mortality, but there was higher vegetative state was seen. But in the moderate disability and good recovery group, there was hardly any difference. They were similar. In what I think that timing of decompressive connectomy is very, very important, which prevent the pathophysiological changes. So, advantage of decompressive connectomy is shorten the mortality benefit, shorten the ICU stay, less ICP targeting intervention, and lower the ICP finally. And this study also showed very nicely that in the 24 cases, 33 ICP was reduced to 9 after decompressive cranectomy. I want to share a few of our cases. Here, the patient presented with road traffic accident, patient was unconscious, and this is showing the surface contusion, and then there was not much midline shape. After 2 days, patient showed the increase in surface contusion, and basal system was also failed. So DC was planned, and we did the decompressive cranectomy and augmented duroplasty was done. And this is our incision, and this is after 2 days of the surgery, showing no midline shape. Condition is very good, even there is subdural effusion slightly, and patient improved, eye opening on the command, incomprehensible sounds, and localization was there. So patient definitely improved. This is another patient showing the generalized edema. Decompressive connectomy was done, and after a week, patient improved, started eye opening, and we hope that this patient will have a good outcome. We also done in few of our cases before the ICP monitoring, and we found that which was continued post-operatively. So we found that in cases where the ICP was more, patient underwent the severe disability stage. So decompensated connectomy also has the complications like brain herniation, delayed paradoxical herniation, subdural hygroma, infection, bleeding, post-traumatic hydrocephalus is a very big problem, and sinking flap syndrome and bone resorption. Here, patient presented with road traffic accident. Patient was unconscious. There was thin subdural hematoma, and there were large decompensated connective was done. This is the defect seen here, and showing the shanken bone flap here. And after 6 months, and this is after 6 months, patient had mild weakness of the left side. So, and there is a just see the deepening of the flap. So here we are planning to do the cranioplasty, and we hope that patient will improve this weakness after cranioplasty. Here again, patient presented with road traffic accident, decompensated connective was done, and patient undergone the persistent vegetative state after 3 months. In this case, patient presented again as a road traffic accident. This is subdural. Patient lost after some time of surgery. We don't have proper guidelines for DC. So in this here, the patient presented to us with subdural hematoma. Patient was unconscious with dilated pupil, but attendant forced us to operate this patient, and we operated, but we lost the patient after 3 days. This is another case where there is subdural hematoma. So this patient post-operative of the hydrocephalus, subdural hygroma, and we did cranioplasty in this patient after 3 months, and but patient improved and started obeying command, and so it was good outcome of the patient because of the cranioplasty. In the case of the bone defect, and this is a very big problem in decompensated cranioplasty. In our cases, we keep the bone flap in the abdomen, or nowadays we have started the correcting this bone defect by 3D technique. So here, just see the large bone defect. This is the large bone defect. Just see here, and this is the mold, and this is implant we are preparing by 3D technique, and this cost 150 US dollar, including the material. I think this is the cheapest of the world we are doing. And nowadays we are not preparing the mold directly. We are getting the implant from the company. So this is the implant. See how nicely this fitted, very nicely, and very good approximation of the flap and good cosmetic outcome in the patient. So we searched the literature recently, and we found by in the literature that recently the Sumit Sinha has done this study in 1200 some cases, and he found that 7.5% patient undergo the persistent vegetative state, and in 77.8% have favorable outcome GOS 4 and 5. Though the DC is superior to standard medical treatment, which is proved by Cohen's database study, which recently published, and also says that the timing is very, very important in the cases. In our department, we have done about 119 cases this year, because the cases number were less because of the lockdown and COVID problem. But every year we are doing 250 to 300 cases, and we found that the time is very, very important for the decompensative cranioplasty. So just I want to tell that decompensative cranioplasty carries although high mortality, but overall, if done surgery timely before radiological or clinical deterioration, outcome is good. Thank you.